This is GB News Originals, and today we're going to ask a disturbing question. Are deadly cancer delays becoming the new normal in Britain? More than 100,000 cancer patients in the past year alone waited longer than the NHS's 2-month target to start treatment. Survival rates in England have stalled, and in some cases, patients fare far worse than in Australia, France or Germany. Around half of all cancers are now diagnosed at late stages, many in A&E. And this number has grown, not reduced, over the past 7 years. And to help us make sense of what's happening and whether government plans can fix it, I'm joined by one of the world's leading cancer specialists, Professor Karol Sikora. He's a former advisor to the World Health Organization on cancer care and a long-time campaigner for improving patient access to diagnosis and treatment here in the UK. Professor Sikora, welcome to GB News Originals.
Thank you.
So, Professor Sikora, more than 100,000 cancer patients in the past year alone didn't start treatment on time, and around half of all cancers are not being picked up early. From where you sit, is this the new normal for cancer patients in Britain? Long waits, postcode lotteries, and worse outcomes?
Sadly so. You can get absolutely world-class treatment and diagnosis very speedily in the NHS, sometimes, but not always. And the post-COVID new normal is very much a clunky system. It's impossible to get to see your GP quickly. When you do, he or she has to write a referral. It takes time to get the 2 diagnostics you need for cancer, which in most cancers you need an image of where the cancer is. That's a scan, an MRI scan or a CT scan. And the second thing you need is a biopsy, a piece of tissue removed so you can look at it under the microscope to prove that it's cancer. That can take 2 months to get that sorted out. Now, the real problem, Lucy, is that stage 1 cancer, which means it's confined to the organs in which it arose, so breast, lung, prostate, and colon, for example, it's curable in 90%. Over 90% of people can be cured with stage 1 disease. The problem is that the disease doesn't stop at stage 1. It starts spreading. First of all, it comes out to the local lymph nodes. Then it spreads into the bloodstream to the liver, the brain, the bone, and so on. There are different patterns for different types of cancers that we can recognize. And the problem is, once the disease spreads, the survival figures go down dramatically. So stage 2 for most cancers is about 50% survival, and stage 3 or 4 is less than 10% survival. So you've got to treat it early. Now, about 10 years ago, the NHS came up with a plan. I think I was on the committee for the plan to try and speed the whole thing up. And we said from diagnosis to treatment should be 28 days, 1 month. It just couldn't be met. So it's stuck at the very old target of, as you say, 2 months, 62 days. And that really is a disgrace in the modern world. There's nothing wrong with the treatment facilities, radiotherapy, chemotherapy. There's nothing wrong with the doctors, the nurses that run the cancer services. What's wrong are the delays in getting to the front of the queue. And that is the biggest problem we've got.
So you think the actual targets themselves should be moved? So what happens in a month or 2? I mean, is that such a big deal with cancer?
I agree you can't go from 62 days to 5 days overnight, but to have a 62-day target that's not met is a disgrace in the Western world. Poland, my father was Polish. I go regularly to the oncology center in Warsaw and Krakow, and I'm just amazed. Their target is 7 days, and they're achieving it in 95% of patients. There's always some, there are delays, they're elderly, they miss appointments, they get ill and so on. But 7 days is quite a good target. In France, you'd be starting treatment the next week. Same in Switzerland or Italy. Italy is the most chaotic system from the outside when you look at it, but it works. And you start cancer treatment, breast or lung cancer, you'd be in almost the next day to start treatment. We just can't do that. There's a sort of apathy here about it. And in America, the United States, you'd sue if you had to wait 62 days for a provider to give you cancer treatment.
You've said in the past that every month delay is the equivalent to a 10% increased risk in death. I mean, we've spent, I think that's right, isn't it? In reduced risk of survival. But our NHS budget is huge and it's grown even bigger. So it's over £100 billion. I think it's 10%, more than 10% of our GDP. The government says it's got a cancer plan. It's put more money into diagnostics. It says it's diagnosing far more people now. Can you just explain why we're not getting on top of this?
I think the problem is just access into the system. Once you're in it, and once you've had the definitive tests that you need to plan the cancer treatment for you, you're fine, you get moving through. But there are serial delays. It's like an airport on a bank holiday. Everywhere you go through one queue, then you end up in another queue, and then another queue. And, in a modern world, when we all have mobile phones, you could just press a couple of buttons and you book the whole pathway within 48 hours. You do every test. It sort of worked for breast cancer as an accident. You see, in breast cancer, Mrs. Thatcher, God bless her, pushed forward the mammogram screening program. It's of dubious value on its own, but what it did do is create one-stop breast clinics to help the patients that were found to have an abnormal mammogram. It began in 1989 and has been very successful since. And the one-stop breast clinics are a model of how cancer should be treated. A lady finds a lump, she goes to the GP, goes to the clinic the same week, and there she'll see a surgeon, an oncologist, the pathology will be taken, it will be looked at in that clinic on that day, and a treatment, if she has cancer, a treatment plan will be made for her, and that could start as soon as there's a vacancy for whatever the first treatment is, usually either chemotherapy or surgery. So I think it can be done, and it can be done for all cancers. The last Parliament, the last government, attempted to build what were called community diagnostic hubs. The one before, which was Labour, this is years ago, had the idea of polyclinics. It's the same concept. You've got to have access. At the moment, you're sitting in your room, you find a lump in the breast, or you find you've got some losing weight, you've got bowel disturbance, maybe some blood in the poo and so on. And what do? First of all, you think, is it serious? And then you say, it is probably serious. So, okay, who do you phone? You get some grumpy receptionist on the phone in a GP surgery that asks you a question to try and fend you off. It's like you're being pushed back. I always tell people, if you've got symptoms, please just be polite and be nice, but be assertive. And say you want to get something done, because the delay is in various sections. First of all, the patient delay. Men are much worse at moving forward to get medical help than women, for example. And different people have different attitudes to seeking medical help. After that, it's the system delay. And that's the biggest delay in the whole thing. So anything you can do to push yourself forward, to get to the front of the queue, to get seen, to get treated, could save your life.
GB News just covered a big report about ovarian cancer, which showed 1 in 4 patients are being diagnosed in A&E at late stages. Are there differences in cancers? I mean, the symptoms of that are much more maybe could be mistaken for other things. So you say this can happen in breast cancer. That's very tangible, isn't it? A lump. Do you think we can get all cancers into a place where we can get faster access to treatment? And what's going wrong with the ones that aren't?
I think that the whole idea of the polyclinic or the community diagnostic hub is fantastic, and we should just go ahead and build them. They've got to have. You can't diagnose cancer by examining people. You can't. That's not good enough, and you certainly can't diagnose it by Zoom. So I think what you have to have is a place where on the same visit you can actually have a scan and you can have a biopsy taken. And it's not rocket science to set this up. Once you then have the diagnostics, you have everything. You get the stage of the cancer, the type of the cancer, whether it's an aggressive pattern down the microscope or a less aggressive pattern, then you can come up with a treatment plan. And I think that would save a lot of people. At the moment, it's very higgledy-piggledy what happens. Some people get a very smooth journey, others have a very slow journey. And it doesn't matter which general practice they're in, which hospital they go to, it varies enormously. Certain cancers are very difficult to diagnose. The two most difficult are ovarian cancer and pancreatic cancer. And the reason's the same in both cases. They're in parts of the body where they have to grow to quite a large size before you get symptoms. That means the chances that they spread before you get the diagnosis is quite high. It's not the patient's fault, they just don't have symptoms. And the symptoms are vague, maybe a little bit of rumbling in the tummy, a bit of pressure in the pelvis for ovarian cancer, and discomfort, and maybe a bit more wind or something like that. But, everyone does that. You think you've had a bad dose of some infection, norovirus or something, and you take time before you come forward. And then once you do, you need the scan, you need blood tests, and then you need to go on to treatment. So smartening up the whole diagnostic process. And I'm sure that's, for the last 40 years, I've been banging on about our mortality for cancer is greater than most European countries, now including Eastern Europe, the old Cold War Soviet bloc countries like Poland. And it's not getting any better. And the only way to make it better is to smarten up the whole diagnostic process.
So you talk about polyclinics for just cancer, or polyclinics for people to drop in with whatever symptoms?
No, for everything. I mean, if you look at general practice, it's left in some sort of Victorian era where the poor old GP, there were no diagnostic tests, the blood tests weren't there. It was all touch and feel, and you can set the offices up round. What we need, a proper clinic with scanners in the GP surgery. Why call it a surgery? It's an anachronism to call it. They don't do surgery in GP clinics anymore. They're not going to do an appendix on the kitchen table. That's what they did in Victorian times, So I think what we have to go for is to have a much more professional, and not just doctors, nurses, physiotherapists, the whole thing in a proper centre where you have diagnostic tools that can, and you can prioritise the patients based on the severity of their symptoms and so on. At the moment, what irritates me most, around here, I live to the west of London, and here there's a public-private partnership clinic, and if you get an appointment, say for a knee scan or something, an MRI for a knee injury, it takes 6 months. I mean, this is ridiculous. Why should it take 6 months? It's no more expensive to do it next week than in 6 months' time. It doesn't matter, I agree, for a musculoskeletal problem, but it does matter if you've got symptoms that suggest you have cancer. And that's the problem. We've got to really smarten up the whole process. If you're redesigning a healthcare system, forget who's paying for it, just the whole system, you would have very smart front-end diagnostic access. Even not quite 24/7, but nothing wrong going on till 10 o'clock at night to cover people that are at work and can't get off. It's all right for most professionals. They can take time off during the day to go and get a scan and a doctor. But if you're a checkout girl at Tesco, it's a lot more difficult to get time off without actually suffering financially. So I think we've got to make it much smarter. And it wouldn't cost more. That's the whole thing about it.
Would you get the doctors to be working at 10 o'clock at night or round the clock? That's the thing. And if we've got the kit in the hospitals, do we need more kit in the polyclinics? But I suppose those are all logistical things. Maybe.
Yeah.
The UK ranks, as you say, very low compared to. Can you just sort of talk about that a little bit? We are falling behind, are we? Most G7 nations, is that right? Most of the richer countries.
Yeah. The way we assess it is to look at what's called the 5-year survival, the percentage of patients with a defined type of cancer at 5 years. And the reason for that is when you look at the survival curve, the graph, 100% of people are alive when they start treatment. And as they go along, as the years go by, the curve drops down. And it drops at different rates for different cancers. So breast, it's a very slow drop. Lung cancer, it drops dramatically to about 25% at 1 year and then plateaus off. There's always at the far end of the survival curve that survive against all the odds, and we don't understand why. And it's not their lifestyle, it's not their psychology, they're not fabulous people or something, they've got some gift that allows them to stay alive. They just do, and we don't understand that. And it's not just they're at one end of the spectrum, there's something going on there that we'd like to learn what it is, because maybe we could work out how to give it to people that don't do so well. So that's the survival curve. And if you look at the survival curve for all the common cancers in Britain, they're significantly lower than the average of European countries, including Eastern countries. And that it makes no sense. And we know the treatment availabilities here. The drug companies would like to say, oh, it's because we're not using the high-cost drug, the latest. That's not true. It's nothing to do with that. It's only to do with delays and therefore what we call stage migration, which means from stage 1, very good survival, migrate to stage 2, it starts to drop. So stage migration, because of delay, results in a problem. The other thing, Lucy, is that cancer diagnosis is a reflection of how the whole healthcare system is working, because most symptoms that could be cancer turn out not to be cancer, but you've got to get rid of them. You've got to do the tests to prove that. So the problem we've got is that if the whole system is so clunky, and we know there are 7.4 million people waiting for something at the moment in the NHS, quite a lot of them are going to have cancer. So we're just waiting. It may be for a scan, it may be for a biopsy, it may be for an operation. And, it's a political propaganda piece for the politicians to show they're reducing the waiting list. Hospitals are paid 35 quid a patient if they can get them off the waiting list. The way they do that, phone them up and say, are you still alive? No? Okay, dead. Off the list. Have you had the operation private? Yes, off the list. So, and you get £35 for the phone call. So there are armies of administrators of phoning people up. It's a deadly boring job, I imagine, to find out if they're dead or alive or have had the operation or are better. And I think the other thing, I hate this to be a rant to you, Lucy, but delay is the most powerful way of rationing. If you could get everything tomorrow, you'd have a lot more customers. If you put a delay in, whatever it is, a week, 2 weeks, 3 months, 6 months, people find alternative ways to achieve the same goal, or they get better, or they die, or they go private and get out of the waiting list. So delay is something that all healthcare systems use as a tool. We don't talk about it, and it's not very nice, but it is a tool. But for cancer, delay is a killer. And whilst it may not matter for someone that needs a hip replacement to wait 3 or 4 months, and the waiting time is more than 18 months in many areas for that, it does matter critically if you've got cancer that's potentially curable.
Do you we used to be an area where we did make progress in cancer care. It's been since about 2010, is it, that we've started to fall behind? Can you see why that is? What's really been behind that sort of lost progress?
I think COVID was a special event, and that's hit cancer services all around the world. We've been slower to recover from it. But if you go back to 2010, as you mentioned, the NHS became much more used to significant delays in the beginning of the cancer journey. So getting scans, getting biopsies, getting blood tests, getting to see a consultant is difficult. And now the new normal is you go along, you go to your GP, you're referred to the cancer clinic. That used to be a 2-week target. Now that's gone. That's unachievable, basically. 2-week target to see a consultant specialist. Now, often the first person you see is a nurse who follows a computer algorithm, takes a history, maybe examines you, and you then wait. And the nurse packages it. She or he tries to relate it to the urgency in terms of the cancer. And then you get an appointment to see the oncologist, often 2 or 3 months after you've actually presented to the hospital. Now, that 2 or 3 months is ridiculous, and you haven't actually had the diagnosis yet, so there's no target for that. So then you go and get the diagnosis, you have a biopsy. The consultant says you need a biopsy, whether it's a liver biopsy, a prostate biopsy, depending what the problem is. You get the result of the biopsy, and there you go. It's positive, and that's when the clock for the 62 days starts. So you can see the combined delay, if you're unlucky, could be 6 months. If you're lucky, it could be next week, it could be 7 days, but it's more likely to be 6 months than 7 days. And this serial delay concept is something the NHS suffers from, and there is absolutely no need for it.
But the NHS budget has sort of almost doubled in the past 2 decades, and we are seeing billions earmarked for schemes like weight loss jabs and digital services. Do you think that ministers are focusing on the wrong priorities with cancer patients left waiting?
I mean, I'd hate to feel sorry for ministers, but or any politician, but it is difficult. And of course, it's the problem in this country, which we don't have in Europe, is that the NHS is a political vehicle. So the parties play with it. Our NHS, it's like a religion, a shrine that you can't criticize, the concept of a free at the point of delivery tax-based system where everybody pays in. But of course it's not. People go privately for bits of it. People opt out. They go abroad for treatment. And there are things you have to pay for. If you just look at dentistry and what's happened to that over the last 50 years, it's gone from being a service where everyone has to pay something. I mean, you may get some money back, or if you're on benefits, you may get something, but on the whole, people have to pay for it. So I think the future is about looking at different ways, and the European model, where you don't politicize it, you have public-private partnerships, so the capital can come from private sector to build things. And then, our hospitals are a real mess. When politicians go to hospitals, they only go to University College, which is new in the Euston Road, or Chelsea and Westminster down the Fulham Road, which is relatively new, and it's nice. It looks good. It looks like a modern hospital. They don't go to Hillingdon Hospital by Heathrow Airport, which I can assure you is falling apart. Wickham Hospital, totally falling apart. Huge investments are needed to bring these up to scratch. And we're looking at far more than the total annual NHS budget to get the buildings right. And there isn't the money to do that. And now there's even less, of course. So it's likely we're going to have to get by. And I think if I had wanted to say where the money for cancer should go, it should go in smartening up the diagnostic pathway up front. That's the best place for it to go.
The government's got a new upcoming cancer plan, hasn't it? And it says it's going to put survival at the front and centre, and it's promising earlier diagnosis and new technology and neighbourhood health hubs. So from what you've seen, do you think this is going to deliver, or is this another sort of glossy strategy without teeth?
It's just like the 10-year plan for the NHS, it's fluff. And there's no doubt that it'll concentrate on inequalities in healthcare. The problem is that wealthy, educated people actually use the NHS as it is, for all its faults, so much better than poor, uneducated people. Why? Because it's not at all user-friendly. It's the most unfriendly system. From the GP receptionist onwards, it's not a system that welcomes you into it. It doesn't want you there. That's the problem. Unlike a business, take a budget airline. They want your custom. They'll try and do everything to keep you going. I know people grumble about budget airlines, but they are significantly cheaper than the old airlines of the past. So how can that be achieved? It's achieved by having better processes in place and better software, consumer-friendly ways. I've got an NHS app on my phone, and all I can get out of it are the batch numbers of the COVID vaccines I've had over the years, the booster vaccine. I can't make an appointment with anybody. I mean, this is ridiculous. I mean, it will come, I'm sure, but why isn't it there now? I can book a flight to Paris now in an hour's time on my mobile phone so easily, but I can't get a GP appointment on it. This is ridiculous.
But to increase the amount of private sort of partnerships, is there not a risk of over medicalising things and having people that are put through the system when they need not be, just because there's money in it? Is that not just the problem?
There is.
The NHS,
The American, so the US system is like that. And the US system has been imported in the Gulf countries, in Latin America, and so they're using a US system. So anybody with money or insurance, the minute you have a temperature, you go to an emergency room, they put a drip up on you, they put needles into you, they take samples. Here, you wouldn't even get to see the GP for 2 weeks, by which time you'd be better. So it's a different approach to illness. And so you're right. If you incentivize people to do something, in other words, you only pay a hospital or pay a doctor to do something, you don't pay them for doing just saying this is okay, just come back in a week and we'll just check that it's gone. You get that over-medicalization of things. I always think childbirth very over-medicalized. The good old days, midwives would go out on their bicycles and deliver babies in the community for most of the patients. Now it's a medical model and it's a technology model. And sure, that's needed for some critically ill children and how the baby is presenting in a bad way, but it's not needed for the vast majority of women. It's a natural process. I mean, and the same with a lot of medicine. A lot of short-term infectious illnesses, childhood infections are self-limiting. They do get better. Even COVID, I remember we had all these discussions during the COVID period. It's not a serious illness for most people. There are some, obviously, that die from it and some that are critically ill. And just going back to one thing we mentioned, why is healthcare getting more and more expensive? Well, obviously the technology is going up. The second thing, though, is an aging population. We have more and more old people that are surviving with all sorts of health problems. And that's a good thing. We're allowing people longevity. We're giving the population longevity. But it comes at a serious cost because as you get older, you accumulate disease. It's not a nice thing to say, but it's true. Older people cost more to treat. It's estimated that a 75-year-old costs 5 times in a year for healthcare than a 30-year-old. So that is a significant burden. The more people you have over 75, the more it's going to cost. But it's a good thing that we're allowing people to live longer and more healthy. So today's 70 is the new 50, or I think that's it, and so on, that you have your longevity is now much greater, but that comes with a cost in healthcare.
I think the Dutch spend the same amount on their healthcare for the purse, the public purse, as we do, but don't have the same waiting lists and don't have the same problems. So it's not a question of money, is it? But it's this idea of sort of a social insurance system where you're paying a bit, topping up a bit, so there's that tension in the system. Is that kind of what you mean? We're not overusing it.
Yes. The problem here is that you're right, we're paying the same amount, more or less, as France, Germany, all these countries. Every year we're paying it into the system. So why isn't the system so much better? The whole system is clunky. A whole bunch of health professionals needed to run a hospital, not just doctors and nurses, a whole lot of other people. And they're not working as a unit. In most places, the health service doesn't work it works as a series of silos. The nurses have one management side, the physiotherapists another, the radiographers another, the doctors another. They all have their own little games they play, their power struggles in there. And no one's really in charge. 30 years ago, there was reorganization where the hospitals got chief executives. The name came from commercial world, the idea being a chief executive was in charge and he or she was responsible for the hospital. But the poor old chief executive in healthcare can't go onto the shop floor and start dictating to the surgeons how they're going to do the operations, or to the oncologists which chemotherapy they're going to give in which patients and what timing. So managing healthcare is a fine art. And I think in this country, we've allowed it to drift. I mean, I've seen quite a few cases. I've done some legal reports on cases that have gone, cancer cases that have gone wrong. And I'm just so unimpressed with the coordination of patients' care. often there's been nothing wrong with the technical quality of the care. It's actually been very good, and they've received the exactly correct treatment, but often a year too late because of an error in diagnosis. But you look at it all and you think this is such a clunky system. When you see, of course, my patients, you don't see it because you're just seeing bits that you're doing, so you don't see all the rest in one show. But when you go into a legal report and look at all the notes, you realize everybody's writing in these notes. Most of it's nonsense. They're repeating what someone else has written. What is going on? We're wasting time and money. And that time and money is not getting any clinical benefit for the customer, the patient. So I think we've got to move to a far more consumerist way of dealing with things. And I see the NHS as the budget airline of the future. If we could smarten it up, and I think it could be good. And then on the side, you have all sorts of things you can have. You can have the champagne division of the like on a plane. You can go business class or first class. You can have all that. You pay for that, and that's fine. I think a very interesting concept is fast tracking. Airports, you have fast track for business passengers, and some you can pay to go on fast track, and not £10 or something. Can you do the same for healthcare in the NHS? And that would create such a political furor if you even mentioned it at a committee. I have mentioned it on committees, and you get everyone say, you can't do that in the NHS. And why not? You get lots of money. People say, I want to be seen next week. I'll pay £50 to be seen next week, to have my scan next week. And the revenue generated from that fast track would help everybody to move faster through the system. But that's like a political no-no for any political party. Even Reform won't be able to do that. I suggest it goes against the British queuing system. We all have to wait in line.
Well, unless you got private healthcare, which I think 1 million people took last year, I think something like that. But do you think, going back to the prioritisation, we have the UK Health Security Agency that's busy looking out for new viruses and creating or developing, looking at vaccines and how we can protect people from illnesses that may not kill us. Do you think we need a sort of new task force? We had the vaccine rollout that we spent unlimited whatever money on, and we had someone at the very top, someone solely responsible for kind of the vaccine rollout, and they're accountable for any missed targets. Do you think we need to have something like that for cancer because of the very nature of the disease, that it's deadly? You can't wait.
I think we do. The vaccine rollout was the most successful thing I've ever seen in the NHS. Whether it was necessary or not is another matter, but as a logistics exercise, from absolutely nothing to getting people with clipboards and high-vis vests in car parks directing traffic, to having tea lady volunteers giving you a nice cup of tea, all that sort of thing was just fantastic. And it was done so quickly. And the fact that I've got the batch numbers of my vaccines on my phone still, even though I can't do anything else with the app, doesn't matter. At least I have the batch numbers and the date and the time and everything. It was brilliant. Of course, it was all bought in. It wasn't NHS. It cost a huge amount of money. The software, the renting the places. And I had my vaccines in some athletic club around the corner here, and it was beautifully organized. So you can't fault it. Can you do the same for cancer? Can you do the same for early diagnosis? Of course you can. But will they? I think not. I think it's too routine. And the cancer the vaccine program for COVID was a one-off, and it was. When you look back, you wonder why on earth did we treat it with such, building these hospitals and the conference centres and so on. Where were you going to get the staff for it? Where did it all come from? But cancer is a clear and present need. It's there. So maybe one should look at some way of doing it. I don't think we need the volunteers, although, why not have the volunteers going around the waiting rooms giving cups of tea? But we could smarten it up. And of course, the NHS app could be part of that. And it could do all sorts of things, including giving you all sorts of complementary therapies as well. It'd be low cost and I think very effective. But someone has to drive it, as they did with COVID, as you suggest. There's no one driving this here.
Yeah. It's not a priority, which is odd. And do you think, I mean, the government, I think, has invested or is looking at some of these amazing blood tests that detect a huge number of cancers, and looking at some of the tech stuff that can fix the problem, like bringing weight loss jabs to fix the obesity problem. Do you think that this is, are we years away from these kind of making a real impact?
I think what we're seeing is a lot of positive PR coming to try and suggest that whichever government's in power is tackling it seriously. The early cancer detection tests, MCEDs as they're called, multiple cancer early detection tests, are not well developed yet. They're not really worthwhile putting out to the general population. The real problem are false positives. So people that have them are worried well. They cost about £900 a bang to get one. So they're worried well by them. If they're positive, who knows? They've got no symptoms. It's claimed they may be able to pinpoint where the cancer is coming from, but that's pretty much sales marketing. There's not much data for that. And the result is that you've got worried well people becoming very worried well. And the only way to try and resolve it is to do a total body MRI, which costs £2,000 or £3,000, and every blood test known for all cancer markers. So you're creating, until we have an effective test, it's really not worth introducing it. And it won't reduce the demand for diagnostics, because of course, if your test is positive, you're going to have a diagnostic such as a scan and a biopsy anyway. So, and you would have eventually presented. So it's not really going to be hugely advantageous. I think the future will be about trying to predict who's going to get cancer by doing sophisticated blood tests to say that Lucy, your risk of breast cancer is significantly above average, therefore you should have more screening for breast cancer. Maybe I would have a significantly more risk of prostate cancer, and therefore you should actually do some regular testing. If you could risk band the population as the likelihood if they get specific cancers, and if you had tests for those cancers, you could really do something rather good with that. At the moment, the screening tests we have for breast, for cervix, and for colon, blood in the poo, they're pretty. They create a lot of false positives. And a false positive means that you're obliged to investigate it, and obviously you get more worried, and that is a drain on healthcare resources. So in poor countries, sub-Saharan Africa, for example, introducing screening, it's not the cost of doing the mammograms or the cervical cytology for cervical cancer. The problem is the downstream processing of these patients is costly, labor-intensive, and worrying to the families, obviously. So you've got to do a bit of counselling and so on. So again, you're absorbing time on something of relatively dubious value for survival, and so it becomes controversial.
Do you think there is a bit of a problem with governments being persuaded and swayed by PR companies and drug firms? Do you think there's an issue there, even from our regulatory system?
Huge thing. I mean, you just need to read the Sunday papers, which I know you used to write and still do. And, there's always a story. And where it comes. AstraZeneca discover a new blood pressure lowering agent, and it's all there. And it's a $10 billion market, all the rest. That's not there to inform patients. That's there to raise funds, to raise the value of the shares and so on. That's the way it works. So I think you have to take all these press releases from diagnostic companies with a pinch of salt, mainly because they're in a state where they're raising money in Wall Street in New York or in the stock exchange here. They want to show they're doing something positive. Sure, progress will occur, but who knows where it's coming from? And that's the problem. If you could predict the future, we could all become very wise and very rich, I guess.
So just to sort of finish up now, if you had just one lever to pull tomorrow, sort of one action that you could do to stop these sort of deadly delays, what would you do?
I'd make sure GPs could actually request a CT scan or MRI next week. All GPs should be able to do that, and they can't. Often they have to refer to a hospital, to a consultant before they can get it. You can monitor if someone is overdoing it, overcooking, ordering too many. You can give them a phone call and say, "You've ordered 300 in the last week. This is too many. You shouldn't be doing that. This is the average." But they should have the power to do that. And that you don't need to do anything. You can use the existing system. Sure, you will be doing more scans, but you will be saving lives by doing that. And I think that's probably the best single thing you can do tomorrow. Building things, streamlining the software, putting apps into people's phones and so on, getting appointments for scans and everything on the same day, so people don't have to go several journeys to a hospital to get their pathway sorted out, is the next step. And then after that, I think improving the whole early diagnostic pathway, not just for cancer, but for everybody. So the whole system, with 7.4 million people waiting, drops to a reasonable level of 100, 200,000 people waiting more than 2 weeks for something. It's achievable, and we should be able to do it.
So what would you say right now to a cancer patient sitting at home, frightened and watching the weeks go by, that is maybe being fobbed off or having to have a long wait for further tests or treatment? Do you have the sort of hope for them? What would you say to them?
I say to them, be assertive, be polite. Don't get cross with anybody, least of all someone on the phone. They have the power to demote you in the queue. But just suggest that if there's any slot that becomes vacant because someone hasn't taken it, you'll come at short notice to the hospital, that you're really worried about everything, the symptoms are getting worse, and you really need sorting out. And I think if you approach it in the right sort of way, it's making the system work for you. The people in the NHS are good on the whole, and they're kind and empathic, and they want to do things, but the whole system stops them doing it. So you've got to come out, and it's not the big boss that you need to be nice to. It's the little people that feel undervalued in the system, the receptionists, the secretaries, and so on. And if you make friends with them, I send them a Christmas card. I had a great story. A patient of mine for years always came at 9 o'clock in my clinic in the morning, first patient, and she was away by 9:20. And I said, "How come you always get the 9 o'clock slot?" I said, "Yeah, I give flowers to your secretary every two or 3 months." And I thought that was great. And I didn't even know. I got nothing. And then she got a bottle of wine at Christmas. So I got nothing. So this is ridiculous. But she was manipulating the system in a nice way. And she knew she wouldn't have to wait if she came at 9 o'clock.
Really interesting. Well, Professor Sikora, it's been an absolute pleasure to speak to you again. Thank you. This is GB News Original.